Hills and Valleys is a podcast that uncovers stories from leaders in healthcare, tech, and everything in between. Straight from the heart of Silicon Valley, we give you a look at the good, the bad, and the future, one episode at a time. Brought to you by Potrero Medical. Hi everyone, this is Omar M. Khatib, Director of Growth at Potrero Medical for another episode of Hills and Valleys. We are coming to you at the end of the conference day here at the American Bern Association in sunny Las Vegas, and we're very fortunate to be joined by Dr. Kevin K. Chung. Doctor, thank you for joining us.
Yeah, thanks for having me.
Absolutely, and just want to give a little bit of background on you. So Dr. Chung is a graduate of the United States Military Academy at West Point and Georgetown University School of Medicine, and after finishing his fellowship in critical care medicine at Walter Reed Army Medical Center, Dr. Chung was assigned to the U.S. Army Institute of Surgical Research, where he has served in the capacity of Medical Director of the Bern Intensive Care Unit, Task Area Manager of Clinical Trials in Burns and Trauma, and the Director of Research for the USAISR over the last 12 years. He's currently the chair at the Department of Medicine at the USU, and I believe now you've transferred to Bethesda, correct?
Well, Bethesda is where the Uniformed Services University is located, and that's where I'm the chair of medicine for that department.
Got it. So just, as background before we get into it, so what got you interested to, go and study at West Point?
Well, growing up, I paid a visit to West Point when I was in grade school. And the minute I stepped onto the parade field, I was sold. I knew that was the only option for me. And so that's the only school I applied to.
Wow.
And I was willing to apply and over again to, if I didn't get in the first year, I was going to apply the next year and then the next year and keep going until I got in.
That's amazing. What did your parents say when you did that?
They were a little bit disgruntled because, we're an immigrant family, and my parents specifically took us out of Korea because there's a mandatory military service requirement, and they didn't want us to do that, and here I am joining the Army.
Wow. Well, just to, get a little personal, so I too am also from an immigrant family. I'm first generation, and just for whatever it's worth, just, thank you very much for your service for people who look and sound and look like me and my family to live very happily and freely here in the United States. We greatly appreciate it and your service.
Well, thank you.
Absolutely.
Thank you for your support.
Now, when in medical school, there's a variety of different things that you can choose to go into.
Mm-hmm.
So what got you to choose your specialty, and what drew you into Bern?
Well, that's an interesting question. Everything happened in stages. So during medical school, I realized that, when you go through the different rotations, really the key is finding your tribe and figuring out what group of people you get along with the most. And after rotating through surgery, orthopedics, OB-GYN, family practice, I realized that internal medicine is where I found it to be most like home, and I found others that were just like me. And so initially my passion was really directed at internal medicine, being a good internist. And for me that meant being a real doctor and asking a lot of questions and being inquisitive and having intellectual curiosity at every turn and trying to figure out what's wrong with the patient and taking very complex medical conditions and simplifying it and getting it down, diluting it down to what the next step should be for that patient. So that's what I got into. So I applied for internal medicine. Believe it or not, my first choice was Walter Reed, but I didn't get my first choice. And it got sent to Eisenhower Army Medical Center in Georgia. And that ended up being the most beneficial thing for me. And in retrospect, that really charted the course of my career. I had a program director there by the name of Bill Brown, who had trained at Mayo Clinic as an intensivist, internal medicine and critical care. And he was just inspirational, and just watching him take care of critically ill patients was very motivating. And I knew after a few rotations with him as my attending that I wanted to do critical care. He just also happens to be the nephew of Max Harry Weil, who is a giant in the field of critical care, the late Max Harry Weil. And if you were at my talk earlier, I talked about lactate, and Max Harry Weil was among the first investigators that basically promoted lactate as an endpoint in the clinical setting. And he's considered widely as one of the fathers of critical care. And so with that relationship, because of that relationship, I tagged along with Dr. Brown to various critical care conferences and met giants in the field, Dennis Mackey, Jean-Louis Vincent, others that attended the conference, Phil Dellinger, and Dr. Joe Perillo. So these are giants in the field of critical care that basically I had an opportunity to meet face-to-face and interact with them, and I really grew to love the field of critical care while I was doing my residency in Georgia. And so when it came time for me to choose, I did a chief resident year, which was a very, very rewarding year where I took an entire year after graduating residency and took care of the residents as the chief of internal medicine residents. And after that year, I applied for critical care fellowship. In the Army, there's really only one slot, and that was at Walter Reed. So I got up to Walter Reed. It's a 2-year fellowship. The benefit, the nice thing about that program is that you have an opportunity to rotate through all the great hospitals in the Washington, D.C. area. So I had an opportunity to rotate through Maryland Shock Trauma, multiple rotations there, Washington Hospital Center, Fairfax, Suburban Hospital, which is a community hospital, NIH, Johns Hopkins, where I did neurocritical care. So I got a very broad range of different patient experiences, and it was solid training in that, it helped me see that different places do things differently, and just because, you're in one place, there are other ways of doing things that may sometimes even be better. But if you train only in one organization, you may not see that. You may have blinders on and only see one way of doing things. And so that was the benefit of being exposed to 8 different sites, as well as being at Walter Reed and Bethesda at that time, which was a naval hospital. They were separate. And one thing that is striking that I should mention, I was a second-year resident when 9/11 happened. And I remember the day I was in the ICU, and I heard about it, and I knew right away that my career trajectory, it was going to be completely different than what I had imagined before. And knowing that, made me want to go into critical care even more. And right when I started fellowship in 2003, you may remember, that's when we started taking casualties.
Yes.
A significant number of casualties. And so the day I started my fellowship at Walter Reed, I had an ICU full of combat casualty, critically ill combat casualty service members. And it was just had a profound impact on me. Wave after wave of patients would come in critical care air transport. Teams would bring them in, and it's not just 1 or 2 patients. They would come in 5, 10, 12 patients at a time every week, every time there was a flight from Landstuhl. So my ICU experience was shaped by a concurrent war that was feeding combat casualties into the ICU, both at Walter Reed and Bethesda. And so I was, it's tough dealing with young service members being so severely injured, but it helped me as a physician grow and learn from having the opportunity to treat them. And so by the time I graduated, there's a person in the Army called the consultant that tells you where you're going to go, and I met with that consultant, and I asked him, I told them, I really enjoyed Eisenhower in Augusta, Georgia. It's a small community hospital. They have a great critical care team. I would like to go back there. And he looked at me and said, "You're going to the ISR." And I looked at him back and I said, "What's the ISR?" I had no idea. And he said, "A U.S. Army Burn Center." It's synonymous with the Institute of Surgical Research. So around here in the burn community, everybody knows what the ISR is, but at that time, as a naive fellow, I had no idea. And so that got me excited because it was a new experience. My wife wasn't fond of and thrilled about moving to Texas because we grew up in the East Coast. We made our move, and the day I started as staff during that summer, that was when the burn casualties started ramping up. And so similar to what I was experiencing at Walter Reed, we were getting wave after wave of burn casualties. And the first 3 years of my experience at the U.S. Army Burn Center, collectively I took 10 days off. I worked pretty much every day.
You can take
weekends included. I just felt obligated to be there because these are service members. You can't go home.
Yeah. Their pain's not going to stop.
Right. And so it was a difficult time in that we were extremely busy. We had very, very sick patients. They were coming in all the time, and I knew it was temporary, but I felt an obligation to be there. And so generally when somebody starts as a staff, you may accumulate X number of patient touches over the span of 10 years. Well, I had that experience abbreviated and shrunk down to 3 years. I had basically, I had the ability to and had the experience of following patients from day of admission all the way through discharge, and some patients were there for over a year in the ICU. These are burn patients. And so, it just, when you're there every day, you notice patterns. You notice very subtle things that occurs from a day to day. And I think that helped shape me as a clinician, and it really, really made me a better doctor, being at the bedside every day. The thing that, made me alter my work habits and my tempo was my deployment. And so in 2008, I got deployed to Iraq, and believe it or not, the Combat Support Hospital in Baghdad, the Baghdad ER, probably the busiest hospital during that time, and it was very busy during that time. Believe it or not, that was a break for me. Going from the burn center, being there all the time with very, very sick patients, and then getting deployed to a combat support hospital. It's ironic, I know, but that was a break. Yes, we had stretches when we were just, mass casualty after mass casualty events, full ICU, very, very busy. But that's all I had to deal with, just taking care of patients, working out, eating healthy, and sleeping. And so that was a good break. So when I got back, I realized in order to survive in this field, I needed to take care of myself. And so I started cutting back to normal ICU schedules. For example, an intensivist generally works about 14 to 15 shifts a month. In our model, that equates to 2 weeks a month, 2 to 3 weeks a month, and the other week I had an opportunity to do admin and research. And so, not that I wasn't doing research before, but when I got back, I had a ton of projects going, and that time that I was not in the ICU, I was able to dedicate to research. And so that's how I ramped up my research activities and my research portfolio. I had the fortune of working with John Holcomb, who basically, he's just an innovator and I would say a giant in the field of trauma, and Steve Wolf, who's also a giant in the field of burn. I had the fortune of working with them and really learning from they were role models, and I saw how they operated. Operated in terms of the way they thought, the way they produced and wrote, and the way they came up with clinical questions, the way they finished projects. and I learned through their example how to start, execute, and complete research. Both of them ingrained in me that a project is not finished until you have a PMID, PubMed identification. So basically published. If it's not published, then it's not done. Obviously, not every project results in publishable material, but by and large, for example, just presenting even in a plenary session at a major national conference, you're only halfway there. You got to get that work published and get it into a manuscript that's generalizable and that's searchable by anybody anywhere.
And that makes sense because, when I was looking at your bio earlier, I couldn't help but see, but I'm going to read it from here, that you have authored over 180 manuscripts in peer-reviewed journals and authored about 13 book chapters, and you've been invited as a speaker at 85 lectures internationally. And you look fairly young, so you've done a lot. And it's your story is remarkable, and it sounds like two things came into your life, which is your environment threw unbelievably difficult obstacles at you that really tested you, your character, and you had the fortune and luxury to not have one or two or three, but multiple mentors that not only guided you and provided their wisdom, but stretched you.
Yep.
So I'm wondering, what was the most memorable thing that you were ever told from all of your mentors? And I know that might be tough.
Yeah. So John Holcomb sat me down the first week, and we had our initial counseling, and basically, we had a nice introduction, and he looked at me and said, "Do you know why we're here?" I said, "Why?" "We're here at the ISR to change practice. Everything that we do, we have to gear it so that we produce some type of new knowledge or some type of therapy that is going to change practice and alter the way we do things, because the way we do things in the status quo is not enough. It's not good enough." And I learned that firsthand with my first group of combat casualties that came in who were burned. And they were basically a group, platoon that had an element that were in a Bradley fighting vehicle, and they hit a improvised explosive device. The vehicle caught on fire, and one of the individuals, I can say his name because he passed away, and it's public record, Alwyn Cash, he was the platoon sergeant, got out, saw the vehicle burning in flames, knew that his squad mates and his platoon mates were trapped inside the vehicle, went back into the fire and pulled his men out. He was the most severely burned. There were about 6 of them, actually 8, and 6 were critically injured. What we observed once we received the patients is that in retrospect, what had happened, they got excellent care downrange, but there was no record of the resuscitation and how much fluids that they received from evacuation point to evacuation point. We call them echelons of care. And so by the time they got to Germany, they had 3 or 4 different handoffs with no documentation or very little documentation of what they had received in the prior echelon. And all 6 of the critically ill patients developed abdominal compartment syndrome because they were all over-resuscitated. And so they need to be decompressed. And if you know anything about burns, having a major burn and adding to it the stress of an open abdomen is a death sentence. And I experienced that firsthand with this group where within the first 48 hours, my first guy died. Within 3 weeks, all 6 service members that I received that day died. And so, that made me, and the team, the entire team, we were scratching our heads And it just so happened that something called the Joint Trauma System had just been set up, where from the ISR they coordinated a teleconference, a simple teleconference with every combat support hospital in theater, and there were a dozen, as well as level 2 facilities, which are one step below combat support hospital. And we were able to communicate not only with those downrange hospitals, but also Landstuhl and Walter Reed. And we got together every week to discuss patients that were transported through Landstuhl. And so through that mechanism, the Joint Trauma System, we were able, and this still exists today. They still have calls every week, and they do, CME, and stuff, lectures, so on and so forth. But back in the day, we would basically go over every patient. And so when we experienced this group of patients and the outcomes that resulted, we talked about it online and to everyone. And so we put our heads together and we decided, hey, we need to figure out how to document resuscitations better. And so overnight, the Landstuhl team, combined with the ISR, came up with a flow sheet with Bern practice guidelines over the weekend. And by Monday, we had a Bern flow sheet and practice guidelines that we pushed forward to every single provider in theater. And that next Thursday, when we had the weekly conference, we emphasized that if you get another Bern patient, you need to use this Bern flow sheet, and this Bern flow sheet must follow the patient throughout the evacuation. Mm-hmm. And so what that did is helped us as a system sort of record and figure out exactly what was going on with the patient, because you were recording it every hour. And it allowed in this system for providers, when they were getting the handoff, to know exactly where they were at. And that intervention alone cut our combined endpoint of abdominal compartment syndrome and death by half. It decreased and improved outcomes by 50%. And so, we published that experience. And so that was among the first few papers that we published. And, going through an experience like that, where you see a problem, you come up with a solution, and this was a collective effort, and you document it, and you show, and you see a significant impact, that was very motivating. And that's, and furthermore, when these patients died, they died of shock, overwhelming shock, and there was nothing I could do, despite me getting high quality training, state-of-the-art training at during my 2 years at Walter Reed. I was out of options. I could not. There were no other interventions that I could that I had in my tool bag at that time, and so. When you lose somebody that you shouldn't have lost, that's a powerful motivator. And so concurrent to the Bern flow sheet effort, which ultimately we basically converted into an algorithm, automated algorithm, and patented the idea, and it's now, and licensed it, and it's now the Bern Navigator. So you may, they're here at the American Burn Association. And it's a FDA-cleared device that basically tracks the resuscitation, and you're able to use graphics. And so that's the result of this experience. But concurrently, because I had dealt with shock and AKI, and at that time, the options that were available to us were not sufficient. For example, we only had the ability to contact nephrology for intermittent hemodialysis. In a patient that is 20 liters positive on multiple pressors, and then they go into AKI, severe AKI, stage 3, intermittent hemodialysis ain't cutting it. You need to do something else. They'll hemodynamically decompensate. So it was they just can't tolerate the hemodialysis. And so it became a root pattern where we would consult nephrology, because we only had intermittent hemodialysis capability, they would say, well, patient's not going to tolerate it. Even if they did put them on, they would be on for an hour or half an hour, and they would drop their pressure, and they would stop the therapy and move on. And so, I was fortunate to have an experience in multiple ICUs during my training, Washington Hospital Center, shock trauma, and the NIH, where they had continuous renal replacement therapy, and they had mature programs. And so I learned that technique during that experience. And among the few things that John Holcomb sort of directed when I first showed up, he said, you're going to start a CRRT program because we need to have this therapy available for these really sick patients. And at that time, I was met with a lot of resistance because
we have some medical students and residents who do listen to the program. Can you tell them what CRT is?
So continuous renal replacement therapy. So instead of doing dialysis over a 2 to 3 hour session, so you're basically there's huge osmotic shifts. You're trying to remove 2 to 3 liters during that session, and so it's pretty. You're going to have some hypotension. So it's in a already hypotensive patient, unstable patient, it's not the best option if you want to do renal replacement therapy. Continuous renal replacement therapy, on the other hand, you hook up the patient and with reasonable blood flows and reasonable replacement fluid, I choose continuous veno-venous hemofiltration as a modality of choice for various reasons. You're connected 24/7, and so if you wanted to remove fluid, for example, you can do it at 100 cc's an hour. That's a more gentle way of removing fluid, so it's much better tolerated hemodynamically, and
easier on the kidneys, I'm sure.
Well, you're applying it in patients that already have AKI. In some patients, there are other reasons that they go on. They don't necessarily have to meet the traditional criteria. Some of them, they may be hypotensive on pressors, and they stop making urine, and they're already acidotic, and they're 20 liters positive. That's a patient, the writing's on the wall. You don't have to meet arbitrary criteria for, they must be uremic with uremic symptoms. This patient needs something done, or else things are gonna go awry. And so we started this program, and I can tell you another story about prior to starting the program, I had a patient who died because we just didn't have the therapy available. We weren't ready yet, and it was just it was crushing to almost be ready with a CRRT capability, but not be able to offer it to this patient. And nephrology couldn't do anything either because they could only offer intermittent. The patient's on 3 pressors. They're not going to tolerate intermittent. But we didn't have the program set up yet. So once we set up the program, we started treating patients, and immediately we saw results. The first 30 or so patients we sort of documented compared to historical controls during the time when we didn't have this therapy available. And our mortality went from 90% to 60%. 60% is the average.
Fantastic.
Yeah, is the average mortality. And now it's down to about 50% mortality in patients that get renal replacement therapy. It's just better hemodynamically tolerated, and it's now more widely accepted, but at that time in 2005 and 6, it was not ubiquitous. Not everybody, and there had not been enough trials to demonstrate that this was standard of care for these very unstable patients with AKI. We had no other, we were desperate. And so in times of
and when you say
the Bern unit, patients are dying left and right, and we can't just sit there and just let that happen. And so knowing that there was this therapy available, I don't really care what the data showed. Intermittent is just, the fact of the matter is they can't tolerate intermittent. You need some form of renal replacement therapy. We didn't have SLED at the time, which is sort of a slower, more gentle form of renal replacement therapy, intermittent renal replacement therapy. So this was the solution, and starting that program was involved. It required a lot of teamwork. The nurses were totally on board. We were just very fortunate to have a couple of nurses who were former dialysis nurses who were on the Bern team. So they became super users. They trained everybody else. It just so happened that technologically brand new machines were on the market right at that time. Mm-hmm. So timing was perfect. And we started this program, published our results in critical care. That then later translated into a multi-center trial. We got funded by the DoD for $3 million to conduct a Bern-specific multi-center trial. It took a long time for us to get that study published, 9 years, in fact. So that's available in critical care. And then we also concurrently did an observational study. And by that time, I had presented enough times at this meeting, the ABA, that other centers started adopting this very aggressive technique, applying renal replacement therapy, continuous renal replacement therapy in burn patients. And now it's become sort of routine. And our next step, now what I'm sort of advocating, and we have a session tomorrow on Ecmo in burns, is providing lung support via extracorporeal therapy, which is called Ecmo, extracorporeal membrane oxygenation, in those that cannot oxygenate and ventilate on their own. And there were patients that were combining ECMO with renal replacement therapy, and we have an entire session dedicated to that tomorrow. So that's the next step, the next level in terms of moving and changing the standard of care.
So that's really interesting. And, one thing that a mentor of mine and the first CEO that I served, who actually went to West Point as well, Christopher Prentice, he had a quote he would always tell me, which is, you either accept the status quo or you challenge it and invent the future. So I'm wondering, Dr. Chung, what do you see right now as a status quo that physicians need to challenge, and what's the future that needs to be invented?
Well, so, back to ECMO, the current standard and the current philosophy is that because in order to execute ECMO, you got to fully anticoagulate the patient. It's relatively contraindicated in burns because burn patients bleed a lot, and they need surgeries, skin grafting procedures that result in significant amount of bleed. And so the conventional wisdom and the experience of the past suggested that we can't provide, this is not an option for patients who have acute respiratory distress syndrome and can't oxygenate. You just can't do ECMO in these patients because they're going to do worse than not doing anything at all. So it was not offered. And when back to the CRRT program at Brooke Army Medical Center, when in the U.S. Army Burn Center, when we started our CRRT program, we started getting consults, the Burn Center, from the trauma ICU when patients were starting to develop AKI. And so, the Burn Center is very unique in that it's a hospital within a hospital, the U.S. Army Burn Center is. And so although it's based and structurally within the Brooke Army Medical Center, it's under a different command. And so that's why it was possible for us to start the program. But when we started the program and it was very successful, other clinicians around the hospital realized the benefit. And there were, residents that rotated with us and saw with their own eyes how helpful it could be in helping stabilize a patient. And so they would call us. They wouldn't call nephrology, they would call us. And I would go, and we had about 10 of those patients until the hospital commander was like, why do we have two standards of care? What's going on here? And basically directed that this program, the continuous renal replacement therapy program, would be offered throughout the entire hospital. So we started a program for the entire hospital. So they grew. And because of that experience, when the possibility of starting an Ecmo program came to be, and Ecmo became popularized after the Caesar trial that was published in 2011 or something like that, and then the H1N1 experience that was published in JAMA around that same time, demonstrating that for adults, veno-venous ECMO saved lives. And so we decided to start an Ecmo program. And naturally, and it's really a nursing technician dependent therapy. You need to have nurses that are super trained and willing to go above and beyond to administer this therapy. And so we already had nurses with that mindset of, I'm going to do what it takes to take care of this patient. I don't care if it's extra work, and they're not getting paid anymore. For them, they saw it as an additional skill. And so our CRRT nurses were the perfect people to identify as ECMO nurses. And we trained them up to do ECMO, and we basically took that opportunity and started an ECMO program. The first patient we treated had bad toxic epidermal necrolysis where the skin was falling off, but also everything in the airway was sloughing and could not oxygenate and ventilate, and that was our first ECMO patient. And then we haven't looked back since. So that program has now treated over 120 patients. It's a fantastic program. Of the over 100 patients, a good percentage happens to be Bern patients. At first, I personally was a little bit nervous about putting a Bern patient on because of the potential bleeding complication. But we also started adjusting our anticoagulation strategy, where before we were putting them on full dose heparin and we were really nervous about the membrane clotting off. But then after some experience, we realized we could take it easy on the heparin and go shoot for lower levels, and the bleeding complications became less and less of a problem. And for the Bern patients, we decided as a team that we could just stop the heparin and just run the ECMO without heparin for specified period, and they would do okay. And sometimes we would, the membrane, we would need to change it out, but it became so routine that wasn't even a problem either. And so this program is fantastic, and now we're dealing with. So you asked what is the status quo? Well, the status quo has shifted. Now we're treating Bern patients with ECMO. Some of them, actually more than half, require concomitant renal replacement therapy. So now we're providing multi-organ support. So you ask, what's the future? The future is that you're going to be able to do multi-organ support, maybe to include liver support, maybe to include sepsis, extracorporeal sepsis support or therapy, all within one system. And the problem is, the challenge I'm running into now is that these therapies exist in different silos. And so ECMO is owned right now, the lion's share of the market is owned by McKay, the company. And the renal replacement therapy companies are completely different. And so trying to combine the modalities, we just do it in the clinical setting, but asking industry to combine it into one machine, that's a little bit of a challenge. Mm-hmm. Not only that, the FDA is a challenge because renal branch, those folks that evaluate renal products and devices, is very different from the cardiopulmonary branch. And so it's two different departments evaluating the same system, and so they need to get together, and we've talked about this. But anyway, there are multiple hurdles that need to be overcome, but the future is delivering multi-organ support therapy from one machine, and being able to leverage that efficiency to treat whoever we want. Whoever they have to meet the criteria, obviously, clinical criteria based on evidence and experience. But for the right patient, we need to, as intensivists, be able to treat, replace the lung if needed, replace the kidney if needed, replace the liver even if needed, and do it all from one machine.
And what about, one thing that it seems to come up, but sort of on the back end of a lot of conversations, is the effects and the injuries that kidneys sustain, especially with burn and fluid replacement. What can be done there, and is it, even for me coming out of medical school, I don't remember seeing these sort of facts and figures about how how many lives are taken by things like acute kidney injury, and how many people have their kidneys affected?
Right. So, I'm a critical care doc, and I'm not a nephrologist. So this is sort of a joke, but I'm not a single organ doctor. So I think in terms of the global perfusion. And so what's going on in shock is that, it's good to monitor the kidney, what's going on in the kidney, but it's a sort of a marker of what's going on globally. So in the setting of shock, the body's trying to shunt blood to compensate, shunting blood away from the kidney and the gut and the skin to vital organs like the heart, the lung, and the brain. And so we're, focusing on the kidney, it's just a portal to what's going on globally. Mm-hmm. And so in a burn patient, in terms of what I think, you do the normal things like try to maintain renal perfusion by making sure the patient is euvolemic, by treating their shock and making sure their blood pressure is adequate, so on and so forth. That's standard of care. Avoiding nephrotoxins, making sure the fluid balance is right. Mm-hmm. Really, the next level of therapy that right now we don't have is protecting the kidney and sort of applying the concept of suspended animation to some degree. So,
can you elaborate on that? Suspended animation.
Yeah. So at the cellular level, there's mitochondrial dysfunction that occurs when the cells start to have decreased perfusion, and there's at the cellular level dysoxia, and so there's only a certain duration of decreased perfusion that the cells can take. About 30 minutes is all, maybe up to an hour. But beyond that, the cell will die. Mm-hmm. And so is there a way to protect at the cellular level, the organ, such that it's able to tolerate longer periods of, decreased perfusion and dysoxia? And that's what I mean. So there are multiple efforts underway to evaluate, and we call it extending the golden hour, extending the time period that, basically extending the tolerance of the organ to injury, to decreased perfusion and injury. And so, the extreme is suspended animation and basically taking somebody and freezing them to freezing temperatures and then protecting all their organs. That's obviously not realistic, but at the end organ level, specifically for the kidney, if there was a drug that either slowed down the metabolism or somehow protected the mitochondria and protected the sequence that resulted in cell death, somehow there are some candidate drugs, for example, valproic acid is being looked at that has sort of that mechanism and increases tolerance of certain organs to injury. So that's one example, but there are other candidates out there. I think that's the next sort of phase, and that's when we're going to make another leap, is when we have a candidate drug or therapy that allows the kidney to basically tolerate various degrees of insults and just makes it a little bit more robust and resilient. And so that's really the next step.
Fantastic. Mm-hmm. Dr. Chung, thank you again for taking time with us, especially at the end of a conference day. I'm sure your feet are hurting like mine, but we appreciate you spending time with us. And, real quick for all our listeners, what's the best way for them to find and, follow and engage with you?
So I just got on Twitter, believe it or not. So my
welcome.
Twitter handle is @ChungK1031. And I'm Kevin Chung, and you'll find me on Twitter. That's how you can contact me if needed. That's pretty much it.
Fantastic. Yeah, and you're great on Twitter. You shared a lot of great slides. And one final sort of rapid fire question, because again, your stories on leadership and overcoming obstacles, from the time that you applied to West Point and everything else, I have to ask for everyone, one or two leadership books, that you gift to people.
Okay, so Outliers is not necessarily a leadership book, but it sort of gives you insight, and this is from Malcolm Gladwell. It gives you insight as to why people excel. It's not the smartest people that succeed. It's not the most privileged. It's not the lucky few. It's a combination. It's not the hardest working. It's a combination of all those things. And so that's provides great insight into the people around you. 7 Habits is a great book by Steve Covey, but everybody knows that. And then,
not everybody.
So I mean, that's a must read. If you've not read the 7 Habits of Highly Effective People, you're way behind because everybody else is on that train. And then I read something recently, blanking on. Good to Great by Jim Collins. Good to Great is an excellent leadership book, and it's helped me as a chair conceptualize my strategy for how I'm going to move the department and the organization and help sort of align my efforts with that of the university. And Good to Great is a great book that helps you gives you many different levels of items that you can implement that helps your organization. And so those are the 3 books right there.
Fantastic. Well, again, hey, thanks for spending time with us, and looking forward to checking out your talk tomorrow.
Okay. Well, thanks.
Thank you.
Thanks for the opportunity.
Absolutely.